Hello, my name is Sharon.
And I am Mina.
And today we will be discussing how a VR training curriculum in surgical skills can lead to safer neurosurgery. When heading into an operation room, most neuro-oncology patients do not know that neurosurgery is widely associated to medical errors. The current model of training, where a trainee follows a surgeon into the operation room and apprentices under them, has been shown to be ineffective in teaching surgical skills. In fact, how many hours do you think it takes to take a new trainee and turn that trainee into an expert neurosurgeon? Up to 10,000 hours. Plus, they are practicing on real patients, which increases the risk for major mistakes. Therefore, a more structured curriculum is required in order to build these surgical skills and improve patient safety. Enter the NeuroVR, a virtual reality simulator that contains various scenarios for brain tumor surgeries. If we use this as a surgical training tool, we can tackle specific skills in a safe and realistic environment, which the apprenticeship model cannot do. We can also incorporate motor learning strategies. Let me explain what those are. Motor learning performance can be rated from 3 perspectives: acquisition of the skill, retention of the skill after a long period of not having practiced it, and transfer of the skill to new situations. If we tackle all 3 of these perspectives, we can assure a quality improvement.
We propose an international double-blind study to compare a motor theory-based simulation curriculum for surgical skills versus 3 months of the currently established apprenticeship model. We want to know which program builds skills that are 1, acquired faster, 2, remembered for longer, and 3, more adaptable to real life or similar but different scenarios. So each skill that we want to target in the curriculum is measured using a specific metric in the NeuroVR. All these metrics fall under safety, quality, and efficiency categories, but we believe that the number 1 priority in a surgical operation is always the safety. So as you can see, those are given the most emphasis and are tackled first. For the first skill, force application. Well, expert surgeons have shown in previous studies to apply much less force than their novice counterparts because force application is linked to control of their hands. So that's pretty foundational, so that skill will be tackled first. Next, the trainees will work on controlling bleeding and minimizing brain damage, and then we'll move on to the quality category where they must maximize the amount of tumor they remove, and then wrap it up with the efficiency category where they increase the speed of their operation while maintaining the quality and safety skills they had just learned.
First, all residents are evaluated on the NeuroVR to track their initial level of performance. Then they are separated into 2 groups, each with the same number of junior and senior residents. The first group will undergo the VR training curriculum, while the other group undergoes the apprenticeship model for 3 months. Each practice session that tackles a new skill will begin with a video outlining simple do's and don'ts so that they know what the basic movement structure is. This will allow them to acquire the skills faster. Next, the trainees will begin practice. After 10 minutes of practice, they will be given feedback by an instructor. During practice, the scenarios that target a specific skill must vary with factors which affect the performance, and these are called parameters. So, for example, if a parameter which affects the control of blood is bleeding intensity. Therefore, when a trainee wants to practice bleeding control, they are given scenarios that vary in bleeding intensities. This helps them build skills that are more adaptable.
So if a trainee is practicing, say, bleeding control, when do we know that they're ready to move on to working on the next skill, brain damage? That's when they achieve the expert benchmark in blood loss, which has been already validated on the NeuroVR. They have to reach that benchmark twice in a row. Twice because that shows consistency, which has also been shown to be a key characteristic of expertise. Of course, when they complete all of the skills, then their program ends.
We hypothesized that by the end of the training curriculum, simulation-trained residents would show faster improvement, better retention of skill, and better performance on the pig model because the simulation curriculum has been designed to tackle these three perspectives. Now, why is this study important? Medical errors are responsible for about 100,000 deaths annually in the US. In neurosurgery, 78.5% of errors are considered preventable. This is because the apprenticeship model only allows trainees to practice while they perform in the operating room. This is akin to having an athlete practice by training and train by running marathons and races, but not actually working out. Simulation has been studied as a solution in different forms of surgery, such as in laparoscopy, where one study determined that the simulation-trained resident was 5 times less likely to injure the patient than the control group. In aviation, a pilot cannot even enter the plane without having completed and passed a global VR curriculum.
So this study fits into all of this by acting as a gateway towards achieving this goal. It helps us understand just how effective this tool simulation can be in neurosurgery. From the results we gather from this study, we can further research expert performance, motor theories in surgery, and we can improve the curriculum that we already have and make it optimal. That can lead us to establishing it and even globalizing it like they did in aviation. That way, all neurosurgeons will be completing a VR curriculum before they actually enter the operating room, and that means that they'll be entering the operating room with our skills and experience under their belt, and that will help us reduce medical errors and achieve our end goal, having safer and healthier brain tumor patients. Thank you. Okay, well, we want to thank, but...